get started. I get a feeling this TED-style talk is kind of popular, just a little bit. You know, we expanded this room maybe 2 to 3 times as much as last year when we had TED-style talks. I got a feeling next year the ballroom is what we're going to need. But thanks so much, right? Thanks so much for being here. This has really hit a home run. This TED-style talk, and we have some really exceptional speakers. So I know very much why you want to be here to listen. Our first speaker is Dr. Corey Waller. His topic is why what we do in addiction medicine sucks. Right? And actually, when we were talking about how should we describe or entitle this particular TED talk, you could have made it a little bit softer. But when we were asking Corey, so what do you really want to say? He says, what I want to say is that it sucks. I said, well, put that down. So, and I think it really conveys the main point that he wants to share with all of you. So he has expertise in, he's an addiction, pain, emergency medicine specialist in Grand Rapids, Michigan. He works within the Spectrum health system. It's a fully integrated health system with 11 hospitals and over 1,000 employed physicians. He's the medical director of the Spectrum Health Medical Group Center for Integrative Medicine, the medical staff chief of pain medicine to the Spectrum Health Hospital System, as well as substance use disorders medical director at Lakeshore's Regional Partners. So please join me in welcoming Dr. Corey Waller. Oh, you already said.
All right, small crowd. Welcome. There are 3 things we need to survive. We need food, we need water, we need dopamine. So dopamine is this chemical in the brain that makes us get out of bed in the morning and makes us go and get food and water. Sadly enough, it's also the chemical that creates love, and that's why we sometimes connect with the wrong food on the wrong days. But we need it to survive. And so without this chemical in the brain, we don't have the capability to get out of bed, to put on clothes, to go to work, to create relationships, and not really have this ability to be made better than what we were the day before. So without this chemical, we don't become the humans that we want to be. I guess so I'm going to have to step it down a little bit, volume-wise. So without that, we have the inability to move forward with the daily things that we need to be able to move through. So let's talk a little bit about dopamine, because it is the crux of and the final common pathway of addiction. And if we're treating addiction, we have to understand that if we don't keep this chemical at the center of this and wrap the patient around that there's really no way for us to get someone better long term. So if we look at the normal amount of dopamine that a brain makes, and it's a little area of the brain called the nucleus accumbens, we look at wake up in the morning, 50 nanograms per deciliter. Now, we've tested this. We've put little pipettes in brains of little mice and monkeys and then functional MRIs and all of these things. So we know that when I wake up on a Monday, maybe it's 45 on a Monday, but in general, we get 50. That gets me out of bed, gets me to the coffee, gets me to work. Best day of my life. Won the lottery, 2% body fat, sitting on a beach, all good, right? All of that happened at once. You get super happy. That's 100 nanograms per deciliter, so it doubles your daily. Now, that's a really high amount, but the issue is that it still allows us to assess risk. I can still say I'm really happy, but I'm going to actually look both ways before I cross the street. Let's say best food ever. We've tested these things. Best food ever, 96. So that's good. So your favorite food done perfectly and the right ambiance gives you all of that. Sex, 92. Bummer. So we're all stuck with food still being the thing that we need. So what happens, right? So what happens if we take methamphetamine? You know, this little drug that I think most of us in this room have heard of and have had to deal with at some level. 1,100 nanograms per deciliter. Instantly. 10 times what the brain is supposed to be able to take. Heroin about 975, marijuana about 650, tobacco about 450. All of these things, by orders of magnitude, raise the amount of dopamine in the brain that we need, and that's not good. Because what happens long term is the body fights back like it always does. So it says 1,100, I don't like that. I'm going to make 1,000. I don't like that. I'm going to make 800, then 500, then 200, then 100. And now all of a sudden, on your best day ever, you're at 30. And your average day is 9. That keeps you from actually getting out of bed and going and doing these things. So what does that do for the body as far as drive and behavior? We look at this lack of dopamine, and we know that it's the crux of our ability to get out of bed and get food and get water. So how does it compare with someone who's starving or dehydrated that can't even, get food or get water? So we've looked at this, and we've put patients in functional MRIs, and we've looked at their brains to determine what is this amount of craving that we would have for food or water when we are starving or basically dehydrated. And we did this by having no fluid intake for 3 days and no food intake for 5. Tested patients, put them in the MRI, talked to them about waterfalls and, dropped water on their legs and had running water and all of these things. And then we looked at the brain to see what that is. And that water gave us ultimately about the size of a baseball for craving. So what happened with food? Food was, you talk about your favorite food, and you're laying there, and we smell it, and you're like wafting it into the MRI tube, and literally. And Dr. Apkarian at Northwestern, who was doing some of these studies, he said he had a hard time not actually just finishing the food before they got out, and had a couple of patients not real happy with that. But at the end, these patients had about a basketball size. So we had a baseball size when your body's about to die of dehydration, and we had a basketball size for people who are about to die of starvation. So 5 days with no food is a long time. That's what the body is really kind of at its max. So what do we do with patients who are 30 days clean? We looked at earlier and we looked at later, but it all still looked basically the same. At 30 days clean, we put somebody in a functional MRI and asked them just to describe the drug when they used it. That was a baseball field size of signal in the brain for craving in the lateral bed nuclei. So we now have an understanding what craving is for a drug as compared to food and water. That was something that helped me to really understand why the behaviors that we see happen, why these very illogical things happen, because it purely is survival. At that point, the body has flipped over from thinking about logic and competing risks and risk adjustment, and I'm not going to make a pro-cons list of why I should go down to the corner and buy some crack and smoke some crack. That doesn't really happen, right? There's a reason. Because without dopamine, the body knows that it's not able to even go after food and water, so it sees it as the core requirement for survival. So if we have the core requirement for survival that is 1/10 of what it could be, that is going to put somebody in a space of behavior that they will do anything to get it. So if it is logical that we have low dopamine and we want to raise dopamine, what will we do? How do we do that? If we have low serotonin, what do? We have a medication, SSRI. We raise the serotonin level up a little bit. Then we do therapy that locks in those behaviors long term, teaches coping, has cognitive behavioral therapy that changes the way that we think and behave about that thought. We have mindfulness that allows people to relax within themselves and to be able to be comfortable with the current situation. That's not really the case in these patients with dopamine that's so low. What they get is the Charlie Brown effect in therapy without raising this dopamine. They get rah, 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 shouldn't do this, rah, rah, be in court, rah, rah. It's nothing. Because I ask them 2 days later when we see them. So we'll see them and we'll have a therapy session. They'll come back and I'll have a conversation. So what did you learn from our therapy last 2 days ago? I was here 2 days ago. Is mostly what I get. And the answer is yeah, for a long time. And we worked really hard. We gave each other high fives. And they're like, yeah, I don't really remember being here. So good luck with that. And these patients cannot onboard the memory either. So dopamine has this really interesting aspect as well. If you have low dopamine in the nucleus accumbens specifically, you can't form long-term memory for new input. And so with that low dopamine state, you can teach them all you want. You can teach them the skills for coping, the way to get to the bus, the way to talk to their children, the way to interact with their lawyer. Whatever it is, it goes out of the brain the same day we teach it. And we get frustrated by that, right? We just say, God, we just went over this and we went over this. Lack of dopamine does not allow for long-term memory to settle into the hippocampus. It just doesn't happen. So how do we raise dopamine? Well, if we look at opioid use disorder, we have two very good ways to initially raise dopamine: buprenorphine and methadone. These are medications that indirectly, and if given at right doses, raise dopamine back up to the level that it needs to be. Not this super therapeutic pathway, not 1,000, not 500, but 40 to 60 to get them out of bed, to have them be, quote, retained in treatment / motivated enough to get out of bed to go to treatment, to show up to the doctor's office, to show up to, family court, to show up to, family therapy sessions. So if we have this, why is it that only about 10% of patients are on medication? So this was interesting to me. My initial training was in emergency medicine. So I thought when I trained in Philadelphia, and I thought when I moved to Michigan, I was going to see what I saw in Philly, which is a lot of trauma and, all the fun stuff that you see on TV. And then I go there, and what I see is what I do now, which are patients with chronic pain, addiction, behavioral health conundrums, and the whole bottom stripe on Maslow's hierarchy just completely wiped out. So how can I motivate someone with no dopamine and no housing and no transportation? Go get them. Yeah? Hope. Pictures of unicorns and rainbows doesn't fix it for these patients. It just doesn't. And so what we have found is that we have now broken addiction treatment into two platforms: the haves and the have-nots. And when I say the haves are the people with a social structure. The haves are the people with family who still care. The haves are people who still may have a job that they can maintain. The haves are people who have children that back them in a society that does not malign them. The have-nots are those that do not have any of those things. They have unstable housing. They don't have transportation. They don't even really have safety. They don't have people who care too much about them, or at least they don't perceive that from them. What we found in the literature is that the group of haves, and I'll use the very specific one, is physicians in recovery. So health professional recovery programs use abstinence-based therapy really pretty successfully. 85 to 90% positive results. In fact, Florida has one of the highest rates of recovery in the physician group at 92%. That's a crazy number, right? 9 out of 10 beat a chronic neurobiological disorder. That's amazing. So how do we do that? Well, they have to call every night between 10 and 12 for 5 years to determine if they have to pee in a cup the next morning. They get full wraparound engagement. The vast majority of them have families that are, behind them, and they still have money. They still have pay to allow them to continue to get this treatment and this therapy. They can do a year of inpatient in recovery. This doesn't occur in who I see. Now, I do see physicians. I have like 3% of my patient load is that. But the vast majority of my patients are Medicaid patients. So about 92% are Medicaid patients. And those patients do not have those things. They don't have any other way to raise dopamine. Your child coming up and giving you a hug in a safe house and telling you it's going to be okay, that will raise your dopamine. If you don't have that, and all you have is somebody beating you down and all that early life trauma that smolders underneath that, your dopamine isn't going to move on its own. It requires help. But right now we have very little penetration for the people out in the community who don't have those things that we would hope that they would have, that we want to move them toward. So this is where it brought me to why I think that what we do for addiction medicine now sucks. Because I'm in charge of a region. I'm a substance use medical director for a region of community mental health. And I've gone and visited every single one of the programs around there. And what one person does and the other person does for the same patient is this much variability. It is all over the place, despite having evidence that says if we use medication-assisted treatment and behavioral therapy, and we give them a roof, that we can have 70 to 75% success rates even in this population. 75% success, I think that needs to be really understood. Diabetes, in the best of situations, is 60% successful at lowering hemoglobin A1C. Hypertension, with perfect medication and even exercise, only 50% of people get a better blood pressure. So we now take a disease that we used to think is not fixable, that is somebody's bad decision, that is somebody's bad day, that if they just pulled themselves up, they could do this. And now we can get, 7 out of 10 in Medicaid patients, in patients who don't have that social structure and who don't have those people behind them pushing them forward. So why is it that we haven't even put into payment schemes and laws and policy a mandate that be absolutely pushed as the treatment modality when the mortality rate is 10 times the amount in those that do not receive it, and if we go down an abstinence-based pathway? 10 times the mortality rate. How effective is 12-step for those patients who are part of the Medicaid system for opioid use disorder? 6 to 8%. Most of the literature for 12-step programs was done on patients with a relatively solid social structure. If it was a drug, it would not pass the FDA. 6 to 8% is a failure. That goes beyond, that's lower than placebo for sham therapy. Sham therapy was 12%. That's problematic, and most of it is, and what we think and our hypothesis is, without the dopamine stabilizing the axis in the brain that allows you to onboard memory, that allows you to onboard the therapy, to change the behavior associated with the thought, without that, it's all wasted time. And the retention in treatment is very low, less than 10%, and that's even for court mandated. So if they don't get the dopamine for survival that they need, they will find it. Medication-assisted treatment is the next aspect, and what we have to do is make sure that we move that forward without impacting, the behavioral therapies that we know works. It is a combination of these things that make the difference. But if we don't look at one, no different than the other, if we use emotion and our thoughts or our likes about a treatment pathway, our belief about a treatment pathway to make a decision for a patient that massively increases their mortality rate, we are breaking this rule that we all looked at when we started in this process. Primum non nocere. First, do no harm. Denying a patient access to the combination of medications or therapy and therapy I can hear. So, are we back? We're up. All right, right at the pinnacle. So I'm gonna roll you back up over the next minute and a half. All right. So as we go through this, I remember the first patient that I ever saw, and I still remember because she died 4 days after I saw her from an overdose. And I had gone through all this training, and I had, done everything that I could to learn this. I'm a neuroscientist. I've got all these pieces of paper on the wall, and I have a lot of loans to show why I have them. And from this, I sat there and I said, you know what? I think we connected. I think we did. So let's see if she does okay on this pathway before we worry about putting her on a medication. 4 days later, I did not have that opportunity. No opportunity. And then when I started digging into the data, thousands of people don't have opportunities. They were seen, and then we have a fail-first pathway. Failure in this disease is death. The final common pathway of addiction is poverty or death. I mean, these are the realities of this disease. And the only way that you escape it is confinement. Most people don't want to spend the rest of their life in jail. They would actually like to be functional and happy and work through this. So the way that we move the needle is to understand that data science and math should rule the day. Belief should not be how we address a medical problem. A chronic neurobiological disease is not just about hope. It's about actually having someone know that they can get to those points in life that they want to get to. And so to deny them the access to the evidence-based things that we have to give them is killing patients. And they're not old patients. They're not somebody who lived a long and prosperous life and they're 85 and we're not going to put them on a ventilator. This is a 22-year-old. This is a 23-year-old. This is a 17-year-old. And if we don't do these things and we don't move this needle from the policy side, from the medication side, from the understanding side that we need to start moving toward the evidence-based model of treatment in every aspect that we do, then we are failing our patients, and more importantly, we are doing harm. Thank you.
Goodness. Oh, yeah, I need you maybe to go over there and do, let's go around this way here. I know, it's getting kind of crazy. No, I have to. Hello. Hi, Gary. Yes, I'm gonna do it from here. Okay, it takes me like 20 minutes to get to that side. So let me just introduce Dr. Gary Belkin to all of you. He's the Executive Deputy Commissioner for Mental Hygiene of the New York City Department of Health and Mental Hygiene. He's also held the position as Senior Director for Psychiatric Services at the New York City Health and Hospitals Corporation. He's also been at Bellevue, a hospital center, and has served as the Deputy Director of the Department of Psychiatry. He's also an Associate Professor of Psychiatry at NYU School of Medicine. Dr. Belkin has been involved in many projects aimed at extending the uses of community-based mental health strategies in New York City and internationally, and exploring the degree that they can be used for larger social policy and public health purposes. Please join me in welcoming Dr. Gary Belkin.
Thank you. Can you hear me? Great. Can you hear me? There was some mixed opinion there. Okay. So I want to take off from the last individual case that you heard about and think about what if we multiplied that thousands-fold? How would we answer the question, where are we going? Where are we going as a system at this time of huge change and transformation? Are we building things knowing where we want to end up after we built them? I started asking myself this question when I was working for the New York City Health and Hospitals Corporation, which is the largest public hospital system in the country with a huge behavioral health footprint. And I saw this map, which is a map of the density concentration of people living on parole in New York City. And I looked at that map, and it looked to me like other maps I've seen. It looked similar to maps of concentration of HIV and IV drug use and overdose deaths, of absenteeism and low graduation rates. It looked like other maps of high rates of psychiatric hospitalization. And I looked at it a little closer, and it reminded me yet of another map, which was of roughly the catchment area of the City Health and Hospitals Corporation. And I thought, here I am overseeing a system that literally resides over these complex combinations of behavioral health issues as factors that fuel and are fueled by a whole host of social outcomes and health outcomes that we care about. And I'm not sure how my system that is layered over all that has an impact on that. How does this treatment system have upstream impact? How does the treatment system have an impact in unraveling and reducing the red, or reducing this red? This is summary data from the Global Burden of Disease study, which, among other things, tried to capture and measure the relative contribution of different categories of disease. So heart disease or cancer, each have a different color on this, and tried to calculate the burden of those disease categories on the population, measured in years of life lived with disability. And the data on the left is summarized for men, on the right for women, but the point is the red. Is disability over the planet attributable to common mental disorders and substance use conditions? So we've got to shrink the red is where I think we should be going. And if we're not building things that are going to help get us there, then all we're doing is building things. And a lot of the activity now in building structures and redesigning care often and historically has ended up being an end in of itself rather than built in mind with a means to another end. And I think it's not just thinking nobly to try to build what we're building now with a sharp eye of where we want to be going. It's not just noble ideas. It's the fact I think we'll build better things with a longer-term objective. We'll invest it differently. We'll build it more smartly if our goal is a public health goal. And so what I'm arguing is where we should be going is to make really seriously mental health the key public health agenda of the 21st century. Now, other parts of the healthcare system are also asking this question of how do treatment systems contribute to health? And in fact, I would say the medical side, the physical side, has been a little ahead of us on this. This appeared in a JAMA question, what is the connection between health care and health? Taking a public health lens really helps us answer that question, because our biggest public health victories show us ways that the treatment system can and should change to be more impactful on population health. You know, we didn't save millions of people from premature death from smoking. We didn't more than halve premature deaths from cardiovascular disease, or bend the curve and stop the march of HIV, or markedly slash infant mortality in this country. We didn't achieve all those public health victories over the last decades by tweaking reimbursement rates or playing with some delivery models. We really decided that these were public health objectives of a first order. And a public health objective brings in the treatment system in innovative ways for sure, but also has all hands on deck, brings other sectors of government, brings other partners, other parts of the community, other constituencies. So what lessons do we have from these that might point us, our treatment system, to be more amenable, more of a partner, more of a force, more of an accelerator of a public health approach to mental health? These are a couple. These are a couple of things when I looked at success in HIV, success in tobacco, of how the treatment systems change their habits to be a partner in having an impact on the population. And I'm going to focus really on two of these and touch on the others. The first around closing gaps and opening access. What making mental health and substance use success as a public health objective, of being as ambitious as those other public health victory examples are. In other words, that we want to end opioid overdose, that we want to prevent all suicides, that we want to make sure that every mother who can have depression prevented has their depression prevented. That if we are ready for those sort of scale of ambition, then we need to really reimagine access. I like this CVS flu shot sign. You know, we'll bring it to you. If we challenged ourselves to make mental health and substance use services as accessible and as easy to get as a flu shot, we're going to start thinking very differently. One different way we might look, one way different that we might start thinking is, reflects work that I did when I was in Haiti, working with Partners in Health. There weren't many, if any, specialized behavioral health providers, but there were a lot of providers. And so what we decided to do, instead of having the people drive the train of care, we had the pathways, the logical evidence-based pathways drive the care. So if you see on the left-hand column is a list of 20 tasks of sorts of things that one has to do within a chain of evidence-based care for depression. It comes from screening, psychoeducation, medication adherence coaching, some sorts of counseling, and then more specialized sorts of counseling, etc. On top, we listed all the people we had to work with: clergy, community members, some doctors, some nurses, some social workers. And it's amazing how much could be done by so many people. So we were able to construct a pathway of care by matching up who we had with what needed to be done. Often we set up our services the other way around. We decide sort of how many people we need, and then we just have them do what they do. I think that the example in the prior speaker about why we don't do more of evidence-based care is because we think about delivering it by hiring someone to do it, not by wiring pathways that make sure we have great flexibility in who could do it. Similarly, what pathways allow us to do is to include more partners in care, that we reach out of our four walls, opening access more and more. The collaborative care model for depression, which people are familiar with, I assume, the genius of the collaborative care model for depression, which assigns roles to people within a primary care team to treat depression. It sort of breaks up the division of labor. What's really smart about that is not what it tells a clinic within four walls what to do, but it writes a pathway for which disconnected people can align their work to do because the pathway drives their work. This really opens up whole new opportunities to design and deliver care by bringing many more people into it: community partners, community-based organizations, faith leaders who in my city want to be trained to do some evidence-based counseling and to screen for people. It links them into a chain of care if we design care as a pathway chain. It enables the healthcare system, therefore, to relate with many more partners in the community, in the public, and thus serve not only as a treater role, but also as an enabler and a coach and a capacity building role, which was key to many other public health successes. It could prompt and enable the health providers to reach into the communities and act earlier. In New York City, we're promoting the use of parent coaching, pro-attachment parent coaching to mothers by mothers. So peer-driven pro-attachment parent coaching as a prevention strategy, but it's one that works because it can connect to providers in this way. The provider role as an anchor, as a partner along a pathway. We need greater incorporation of habits of improvement if we're going to innovate this way. Adoption by behavioral health providers of quality improvement methods has been slower than the rest of the healthcare system. And if we're going to be the incubator engine for new ideas, for changing how we deliver and link up with the community in these ways, we have to be idea testers, and we have to really bring those sorts of strategies into the core of our work. And finally, using better data. The map at the bottom is a map of hotspots of people with uncontrolled diabetes in New York City, which my health department is able to map. And so because they can locate it so carefully, they can train community health workers to go to those projects. This is a cluster of housing projects, to go there and coach their neighbors in self-help behaviors, in how to seek care and understanding what the obstacles are and educating them about their illness. We learned in that project that about a quarter of the people who we talk to in those city blocks have depression. But I can't see that because I don't have the tools to see that. So I can't call a team of local health workers in to help their neighbors with their depression or with their substance use or with their anxiety disorder. So we need better data to see. We cannot launch a public health strategy, a community health strategy, if we can't see the community, if we can't see the public. And there are ways for treatment systems to collaborate to help map what's in their area. Similarly, this is data from a colleague of mine in New York, Sydney Hankerson, who is doing work with faith leaders where he's training them to do evidence-based counseling and screening. And at one church, found rates of depression that we don't see in our research studies. And so the question is, what are we missing? And we can't do a public health strategy if we can't see everything. And so we need the treatment system to be partners in seeing more. So can we do these things? Can we innovate? Can the treatment system indeed be a partner, be a contributor, be an accelerator of an ambitious public health strategy for mental health to shrink the red? It means taking on new functions, new talents, new skills, new ways of doing things. Of course, it would help to do those things if one got paid to do it. So in New York State, we have all the acronyms happening at once. We're doing Medicaid managed care. We're doing health homes. We're doing patient-centered medical homes. We're reinvesting Medicaid saving dollars through DSRIP to try to re-engineer the system. All of those have behavioral health innovation front and center. But I ask of those things, where are they going? And if they're just going to short-term cost changes, they're not going to have long-lasting impact and they won't be built smartly. So a challenge for us is to see if we can steer these opportunities into better design that can help fuel a real public health era for mental health. These are opportunities as the cement is loosened to try to seize. But we won't be able to seize it if we don't know where we're going, if we don't know where we want to end up. And I'm encouraging all of you, where you have opportunities to redo things, is to think about where you're going, and it should be to shrink the red and to participate in strategies that innovate in the ways that other public health victories have innovated. And other countries have done this. Other places have done this. Public health in general as a field has really been changed a lot by this idea of health in all policies. The idea that just the health sector isn't enough to improve the population's health. It needs coordinated action and shared ownership by other sectors of government and other parts of the system. The same, I think, is true, and especially so, for mental health. We need an approach of mental health in all policies. And several countries have gone down that road. Sweden, which launched a nationwide effort to put a focus on adolescent and youth mental health, brought together multiple sectors of government across many cities to function that way. In Canada, CAMH, the Center for Addiction and Mental Health, is sort of an anchor partner to clusters of innovators and communities throughout the province of Ottawa in doing what I was describing, in bringing treatment providers, but then also other community-based partners and social service providers to think together about pathways that make sense and that will capture and reach the fullness of the population to shrink that red. Government of England is far and away, I think, from other countries, perhaps maybe Australia, and thinking about real public health equivalents. What can we put in the water, or not quite the water, but what can we really spread throughout the population that is mental health promotional and preventive and resilience building in terms of well-being skills and access online for any citizen in the UK to therapy for depression. So I challenge you to think about where you're going, and I challenge you to think together and with like-minded folks to build tangible ways that the treatment system is a partner to the next wave of public health, which should be about shrinking that red. We need to know where we're going. Thank you.
Thanks so much, Dr. Belkin. And we have both two calls to action from Dr. Belkin and also Dr. Waller. Okay, we're going to have now our last speaker, and it's a pleasure to introduce her. I'm just going to get her slides up in a moment. Okay.
Wow. I know, really. All right, am I on?
Jeanne, I'm gonna introduce you in just a moment.
Okay, I'm good. Yeah, really.
Okay, we're actually the timing couldn't be more perfect in terms of the series of TED Talks. So it's my pleasure to introduce Jeanne Supin, who guides innovative behavioral health organizations through successful change and toward leadership, management, workforce excellence. She's best known as the lead faculty for the National Council's Middle Management Academy and other National Council programs dedicated to leadership development. She's also she's certified in acupuncture detox, a practitioner of resonance repatterning, and has studied classical homeopathy, classical Chinese medicine, meridian tapping, brain gym, applied kinesiology, flower essences, Reiki, and Wen energetics. She's practiced yoga since 1983, and over the past 30 years has experienced countless sessions in a vast array of alternative treatments, blending conventional and alternative medicine. It's really her lifelong passion, and she wants to share that passion with us. Please welcome Jeanne Supin.
I know, thank you. So a year ago, a woman I've known forever called me and said she was addicted to heroin. I was devastated. I love her dearly. Yet, yikes, what did I do?
Is that the slide you want to be on, Jeanne?
Yep.
Oh, okay, great.
How do I?
Okay, good. You're good.
Perfect, thanks. So again, I was devastated. I love her dearly. Yet I also understood the lifelong trauma she experienced, the lifelong anxiety she experienced. I sort of understood. But this isn't one of those stories. This isn't this tragic up and down addiction story. This is actually a really good story. Certainly it's a story of recovery, and recovery is a huge, important part of my friend's story, but it's also a story beyond recovery toward true healing. Essentially, this is a story about alternative medicine. It's mostly specifically about acupuncture, because that's what specifically helped my friend, but it's also about the vast array of alternative medicine and how they can help all of the people that we serve. Lots and lots and lots of people use alternative medicine. A 2012 study demonstrates that 33.2% adult Americans use alternative medicine, 11.6% children use complementary and alternative medicine. A 2009 study reported that Americans spend $33.9 billion on alternative medicine, mostly out of pocket. Now, most of them, at least half of them, statistics say, are not telling their primary providers they're using it, but they're using it anyway, and we got to assume they're getting some pretty good results, otherwise they wouldn't be spending $33.9 billion out of their own pocket. Yet I can appreciate why it's really hard to understand and implement alternative medicine. And that's because alternative medicine rests in a radically different paradigm than the traditional medicine paradigm that we're accustomed to. They're just two things, and it's a mistake to try to explain alternative medicine using Western medicine's paradigm and language and concepts. So, for example, just a couple weeks ago, I read a newspaper column written by a Harvard physician who said acupuncture works by stimulating endorphins. And I've read lots and lots of articles that claim homeopathic remedies are merely placebos, and so any positive effect you feel is purely psychosomatic. Yet, these aren't accurate. With all due respect to the brilliant physicians and scientists who are making these claims, their understanding of alternative medicine is flawed and it's inaccurate. Not because they don't know their stuff, they do, but it's that alternative medicine rests in a different paradigm. So I'm going to kind of walk you through 3 pieces that I believe really distinguish a Western medicine paradigm from the alternative medicine paradigms. First, alternative medicines are fully holistic. So Western medicine strives for systematic generalization. We want to know the treatments that will serve the widest number of people. We want to look at diagnostic criteria and symptomology, again, that cover the widest array of people, and then we want to figure out what will help the vast majority of people who are presenting with those symptoms. It's generalized, it's systematic generalization. Alternative medicine is just the opposite. Everything is individualized and holistic. So my brain, my heart, and my gut are all integrated in a fully holistic tapestry. When I go to an alternative practitioner, my alternative practitioner is asking me about my physical symptoms, my mental state, my mood, my emotions, and most of them are also asking me about my spiritual state and my spiritual connection. And they're weaving it all together into one system. And then their subsequent treatments are addressing all aspects of myself. So after 9 months of active heroin addiction, my friend went into detox, and she detoxed. And then she subsequently entered recovery, and she was prescribed Suboxone. And Suboxone is a Western pharmaceutical treatment specifically targeting those parts of our brain around opiate addiction. And it's wonderful. Suboxone saved my friend's life. Now, some physicians say you can stay on Suboxone indefinitely, but she didn't want to. So with her doctor's guidance, she, over several months, weaned herself to the smallest possible dose she could maintain without experiencing any withdrawals. And then she enlisted an acupuncturist to help her do the final withdrawal. So her acupuncturist certainly asked her about her addiction history and asked her if there was family history around addiction. But then her acupuncturist asked her a whole bunch of other questions. My friend was born, for example, with underdeveloped lungs. So she suffered a lifetime of respiratory infections and allergies. My friend also experienced some pretty significant traumas, some neglect, some sadness, some untimely, horrible deaths of loved ones. She also reported to her acupuncturist that she had experienced anxiety her whole life. So the acupuncturist was able to take all of these symptoms and pull them all together. So this is a slide of this is an anatomy slide for an acupuncturist. It looks different than the anatomy slides that we see in our typical medical books, but for an acupuncturist, this is just as powerful an image. Acupuncture is a system of bioenergetics. that defines the human body in terms of a whole slew of energy channels that run through our bodies. So this illustration, the lines that you see are energy channels or meridians that run through our bodies. And each one governs a whole different set of stuff that we are. Each channel governs certain aspects of our physicality, certain moods and emotions, certain mental states, and certain spiritual aspects of our being. So what an acupuncturist wants to do is discern, you kind of come in and you describe symptoms in all of those categories, and acupuncturists will put them together in a picture and then create a treatment protocol that will address them. So in my friend's case, her signs, the respiratory infections, the anxiety, her particular expression of trauma and neglect, and her addiction all pointed to a weakness in the lung channel or the lung meridian. And so her acupuncturist addressed the lung meridian and used hair-thin, tiny needles, I swear to you they don't hurt, and applied them to very specific points along the lung channel to release the energy. So the second part, and I sort of hinted at it in the previous, in the understanding that it's holistic, the second difference between alternative medicine and Western medicine paradigms is alternative medicine is really individualized. I referenced earlier that Western medicine is generalized. We're trying to cover as many people as we can. Alternative medicine is very, very specific. We are treating the specific person in this specific moment with this specific array of symptoms. In fact, the best practitioners are so specific and everything is so tailored, and the best sessions with an alternative practitioner are those that could never be replicated, because you're never going to replicate this person in this moment with this set of symptoms. So my friend worked with an acupuncturist over the week she detoxed from Suboxone. She had 4 sessions. And certainly there were certain points that were common through all the 4 sessions. There are 5 points in your ears, there's 1 point in your forehead, there's 1 point in the top of your head that research demonstrates will reduce cravings, will reduce withdrawal symptoms, and will also offer you a sense of calm and groundedness. So her acupuncturist used all of those points for all 4 sessions. But after that, they were all different. So in her first session, she hadn't yet experienced any physical withdrawal symptoms. She was just really, really anxious and nervous. And so her acupuncturist addressed that and used points that addressed that directly. In her second session, she was experiencing some mild, sort of almost like you're getting the flu kind of symptoms. And so her acupuncturist addressed those points. And then by the 5th day of that week, my friend was experiencing no physical symptoms of detox. And so for the 3rd and 4th sessions, her acupuncturist started addressing her much deeper root symptomology related to recurrent trauma, related to grief and loss, and related to anxiety. Every session was different. Now, every session, my friend walked out of the exam room feeling physically better, feeling emotionally calmer, feeling mentally more solid, but the path to get there, each session was radically different. So here's the third difference between the Western medical paradigm and alternative medical paradigms, and I will admit, and I will warn you, this is the one that's probably the hardest to get your head wrapped around, or at least it is for me. Western medicine is primarily based on 3 scientific metadisciplines. Biology, so our bones, our muscles, our systems, our organs. Chemistry, our neurotransmitters, our amino acids, our proteins, and the other chemicals in our bodies that send and receive messages. And genetics, so those traits and qualities that we are born with, that we inherit from our parents and our ancestors. So most alternative medicine systems add a 4th scientific metadiscipline, and that's physics. And more accurately, it's quantum physics. It's the physics of the stuff really, really, really tiny that we don't see, that we can't even perceive with our human senses. Yet that's what's underpinning most alternative medicine. So a very, very, very quick little overview of some of the aspects of quantum physics. Quantum physics suggests that everything, the chairs that you are sitting on, the stage I'm standing on, our bodies, even the carbon dioxide molecules that are embedded in the air that we're breathing, everything can be whittled down to a particle. And particles conform to some very clear, very measurable, very proven sets of phenomenon. Some of those phenomenon, particles can be demonstrated as waves, they can be demonstrated as frequency, and they abide by some rules of quantum mechanics known as entanglement and non-locality. And that's what's underpinning most alternative medicine. It is a mistake to say that acupuncture is stimulating endorphins or that acupuncture is stimulating a neural activity. Instead, what acupuncture is stimulating, or if I can push you like way over the edge, what a chakra balance is stimulating, what a homeopathic remedy is stimulating, what a Reiki session is stimulating, what all these things are stimulating are flows of energy within our bodies that are governed by the rules of quantum mechanics. So we need to understand that, because once we begin to understand those rules, we can begin to really appreciate the power of alternative medicine. We can also begin to really understand and appreciate and create studies that make sense. Because some studies do exist. This is just a short list of the studies that demonstrate acupuncture's efficacy with detox and addiction. This slide shows just some of the organizations nationally that either recognize or support or publish information about alternatives in behavioral health. And then this slide shows just a tiny fraction of the organizations around the country that actually use or integrate complementary and alternative methods. It's everywhere. But there's a more important reason. So my friend detoxed from Suboxone twice in 6 months. And one of those detox, she was not supported by acupuncture, and this is what she experienced. She had pretty acute anxiety. She had pretty acute and significant depression. She suffered from acute stomach cramps. Her feet hurt, her legs hurt, her back hurt, particularly when she was standing or walking. She felt weak, and it kept going. And after 5 days, she couldn't take it anymore, and she ended up returning to her very small dose of Suboxone. Her other Suboxone detox, where she did have acupuncture support, was radically different. She felt no anxiety. She felt no depression. She felt no stomach cramps. She felt she felt a little bit of flu-like pain, but not real pain when she was walking. She sort of felt achy. She definitely had restless legs for several days. She definitely felt weak for several days, but on the 5th morning, she woke up clear-headed and calm and symptom-free. She's certainly still on a path of recovery. Recovery is incredibly important, but all her work with her acupuncturist allowed her to kind of really dive into psychotherapy. And she subsequently has found a psychotherapist who not only integrates mental health and addictions expertise, but also integrates chakra healing and yoga into her practice. And my friend loves her. And my friend's been working with her for months and months and is now really diving into those aspects of trauma and anxiety and a history of neglect that she's now able to begin to heal. 4.2 million Americans have used heroin once in their life, and 23% of them are going to get addicted to it. So this is not just my friend's story, this is their story too. We are a field dedicated to busting down paradigms, like old paradigms that said addiction reflected personal weakness, or said those with mental illness, they'd have to live with their symptoms their whole lives. We knew that wasn't true, and we broke through paradigms that said it was, and we demanded any kind of available treatment that could help somebody. If these 5 tiny little needles that cost pennies to use can help some people detox with greater ease and connect more deeply to treatment and recovery, certainly that is an idea worth spreading. Thank you.
Thank you, Jeanne. Would all of you please join me in congratulating and applauding our presenters today?